Okay, I think we'll get started. It is now 1:30. I can see we've got quite a lot of people have already joined. For those that haven't joined yet, the webinar will be recorded and it will be posted on our NEIAA platform within the next couple of weeks. Good afternoon, everybody, and thank you for joining us. So this webinar today is on improving services for patients. And if you saw the tweet that went out yesterday, it may have been a little bit misleading. You might have been expecting Ed Alvin, but we've got Dr. Liz Price with, with me today for the presentation. So I'm just going to do a bit of an intro and then I'll hand over to Liz. And then towards the end, we'd love to hear for those of you on the call, with feedback from you on what we can do to be supportive within the audit team, and any feedback of struggles that you're having with engagement at the moment, either for yourself or within your department. Yes, so that's what we'd love to get out of today. So our webinar is called Improving Services for Patients, and we've linked this with the launch of our quality improvement plan. So I'm sure most of you will have seen last Thursday we published the Year 5 NEIAA report. It's a very new style of report. It's a State of the Nation report, so it's much shorter than anything we've published before. Hopefully much more user-friendly and easier to read. But alongside that, we also published our quality improvement plan, and that's what we'll talk you through, what those improvement goals are set out for the next 3 years. So the webinar is hosted today by myself. So I'm Sarah Gallagher and I'm the project manager for NEIAA. I've been project manager of the audit for about a year now. And then I'm joined by Dr. Liz Price, who's our clinical lead for the audit. And I'll leave this slide up for a little while. So if you have not had a chance to have a look at our State of the Nation report or our QI plan, there are some QR codes here that you can use to access them. We'll also just drop the link in the chat for you where you can find them on the BSR webpage. If you scroll down, you'll see the report, and then below you'll see the quality improvement plan. Yeah, and that's it there. There's the report there, a fantastic cover. I'm sure you'll all agree. I really like the new style of report, and hopefully it is well received by your teams as well. So Liz, I'll hand over to you now that I've done an introduction.
Fantastic. Thank you so much, Sarah. And yes, do scroll down. Sarah pointed that out because I didn't scroll down and I couldn't find it. You have to keep going down the page when you go into the BSR website, but the links do work. I've tried them on my rather battered smartphone and they definitely work. So the whole emphasis of the NEIAA audit and the reason HQIP have mandated this audit is to improve patient care. We know that, and we do know, and in fact we've got evidence now showing that early presentation, early treatment improves patient outcomes. And those of you who've been following the outcomes of the audit over the last 5 years will know that we've got data showing that patients who start their DMARDs within 6 weeks of referral have better outcomes at 12 months with lower damage scores and HAQ scores and so forth. So we've got very good evidence that early treatment works in rheumatoid arthritis. And our overarching aim for the audit as a whole is to improve care for all patients with inflammatory immune-mediated diseases. And that's quite important because one of the criticisms we've had from patients and patient groups is that actually it was very focused on rheumatoid arthritis. And really, in part because of the patient voice, we've extended it to other conditions. And those of you who've been following it will know that from April this year, we launched that. And in fact, it's been mandated since September. And what we're doing with that is we're asking you to put in data on new diagnosis. We're not actually asking for very much. Those of you who've entered the data sets will know that for those patients who haven't got early inflammatory arthritis, it's just 2 pages. It's the front page with the basic demographic data and the second page confirming the diagnosis. But most importantly, on the second page, both for the early inflammatory arthritis and the other conditions, there is a box for you to put in the patient email. And if I could really push that message today, that we want the patients involved in this, the easiest way to get your patient involved is to put the email in. What happens then is that BSR will contact them direct via email, ask them if they want to participate, and if they agree, then they go on to click a link and they'll be sent 4 questionnaires over the course of the next 12 months, asking them about what impact the disease has on them and everything. And this has been pushed very hard by the patient charities. They want their patient voice heard and they want us to listen to it. And obviously, the more people we can get, the better. So moving on, slides. I'm not, you are. So these are our improvement goals. So when you do an audit like this, HQIP, who mandate and commission the audit. So those of you who don't understand the way it works, the NHS, the governing NHS body, and HQIP, the health quality improvement part of that, commission BSR. So BSR runs the audit on behalf, if you like, of the wider NHS across England and Wales. It's really good that BSR is involved because we are your organisation. We're going to put you first. So we're not going to use the NEIAA to beat you over the head. We're using it to help you improve. And we're using it, we hope, to highlight where departments and trusts in particular need to support you as rheumatologists and the wider MDT and audit departments to deliver the audit and deliver improvement. And the whole idea is this is not just a snapshot in time. This is a continuous improvement cycle. You know, and you should know, and there are little tutorials online showing you how to do this. You can download your data. You can see your data in real time. You can see what improvements are happening. You can put an improvement in and then follow the consequences of that. So what are our improvement goals? And we've set some fairly clear improvement goals that we want to take forward with your help over the next few years. First of all, we want to reduce the time between patients being referred and patients being seen. So I've already told you that starting a DMARD within 6 weeks is a marker of better outcomes. You can only start the DMARD within 6 weeks if you see the patients early. The target for seeing the patients is 21 days, 3 weeks. The actual mean for us seeing the patients is 31 days across England and Wales. And obviously, we want everyone to improve. So this is not necessarily an individual target. This is a system-wide target. This is the whole audit target. So we want to reduce that 31 days by 10% every year on year until we get to 3 weeks. And, you know, if we did achieve that, who knows, we might be able to push it further in the future. We can only do that with your support, and that's about organising your services to see these patients in a priority time frame. And I've been having calls with services about how to facilitate that. The next thing, and I've said this is probably the most important thing, it's not actually what HQIP measures, but it is the most important thing, is reducing the time to starting treatment. Now, if you see the patients early, you can start the treatment early, but the target is to start treatment within 6 weeks. Our current time to treatment is 54 days. And actually we're not as far away from that target as we are from the 3-week target. And that's because most of you have taken on board already the message that really you need to start DMARDs at the first possible opportunity. So if you've made a confident diagnosis at first visit of rheumatoid arthritis, you should be starting DMARDs then and there. But we still think we could do better. And again, annually across the whole broad spectrum of the audit, we want to reduce that time by 7.5% year on year. And, you know, these are quite ambitious targets and we don't apologise for doing that. This is all about patient improvement. And that's why we set these goals. We've got a couple more to talk through. So we want to increase the number of patients being entered into the audit by 20% annually. We know that we miss a lot of these patients. We miss them because we don't think about the audit when we see patients in clinic, or they've come through a different pathway, or we feel we're too busy and so forth. I work in a department where we're pretty hot on the audit. I'm constantly, my colleagues who are on the call today will know I'm constantly nagging about people being put into the audit. But I can tell you that even within our cohort of medics here, there's a tenfold difference between the best recruiters and the least, if you like, in terms of the numbers of people they're putting into the audit. And that means we're missing people. And if you're missing people going into the audit, then you can't guarantee the quality of your data. And quality of data is really important. The more people that are in, the better the quality will be. We have changed the way things are done, and you'll know this, that from April this year, you're not entering all patients who turn up with suspected inflammatory arthritis. You're only entering those patients who actually have confirmed inflammatory arthritis. So what we know from last year's data is that although about 11,000 patients were actually entered into the audit, only 4,900 of those, and that's about 45% or so, were eligible for follow-up, had rheumatoid type inflammatory arthritis or a similar pattern of arthritis. From now on in, we're only entering that cohort. So the overall numbers of people in the audit will drop, but actually everybody in the audit will have a confirmed diagnosis and will provide us with very valuable follow-up data. It has reduced the data burden for you, and those of you like myself who enter the data themselves directly will know that the data captured is far lower now than it used to be. There's far less bits and pieces you have to enter, so we've made it easier for you by linking with the spine. The other target we've got is to increase this from patient-reported outcome measure data. So this is getting more patients to engage with the audit. And again, the push for this has really come from the patient bodies themselves. They feel they don't have a voice. The way to have a voice is to get their thoughts, their concerns heard as part of the audit. So we want to increase that. So we've got a very ambitious target for this. At the moment, just under a third, 29% of eligible patients are entering data at baseline. We want to push that all the way up to 75%. Now, that would be a real achievement if we did that. Most sort of patient surveys achieve 50% or so, but we're pushing harder because our patients tell us that they are engaged and they want their data entered. The next slide. Lovely. So how can we support you to do that? Because as I say, we're not about beating you over the head with a ruler and telling you off. We're about making it better for you. So we've come up with some things that we hope will help. So my slides have gone back there. Well, that's perfect. Okay. So if you go onto the website, there are some case studies from units that have had problems and where they've improved. And there are posters and presentations, both on the website itself. And in fact, there are going to be some posters at BSR next year looking at these particular issues. We're running webinars, you're on one at the moment, and we're producing podcasts. And there are QI resources. Again, these are available on the website, so please utilise them. And if any of you are contemplating entering into the accreditation system, the QRS, there's a lot of QI methodology embedded in that to help you improve as a department. We have produced a very comprehensive workforce report, and I really would encourage you to go onto the website and look at that and share it with your clinical teams and managers. I've been doing one-to-one calls with some of the services participating in the audit. Some of them have been having problems. And I was explaining to Sarah beforehand that I think people fall into two general categories. There are a group of services out there who who are nearly there, but just need to get things organised, get their processes in order and so forth, and who will achieve, and if you like, come out of being an outlier and achieve the audit. But there is also a cohort of services out there, I'm afraid, who are on their knees, who are struggling, who haven't got enough personnel, who are being ignored sometimes by their managers. It's quite heartbreaking in terms of, not believing they haven't got enough workforce to do the job. And actually, we have been able to point that out to managers. Things are starting to move. I think awareness is improving. I appreciate that we haven't trained enough rheumatologists and we're a bit short, but there are things that can be done. So please engage with us if you're struggling, because we're very, very keen to support you and listen to your problems and see if we can help work through them with you. There are best practice guidelines. You'll know I use them day in, day out, particularly the pregnancy ones, particularly the DMOD guidelines. They're really helpful, and using them helps you deliver a really high standard service. A conference is next year, so it's next year now, isn't it, in Liverpool, I think it is next year. We're going to have open access, if you like, to the team. Sarah and her team will be there on the stand. I'll be available as well. So please come and meet us, chat to us, tell us what your problems are. We're very happy to help you engage with the audit and improve. I've been undertaking calls, and I know that Ed, who's based at King's, and various other people from BSR have been out visiting some services. If you think you'd benefit from a visit or a talk at a regional meeting, please get in touch and let us know, because it's a way of spreading the word and actually, as I say, reaching out. And providing letters, as I say, highlighting where services need help from their trusts in order to be able to participate and comply with the audit. So I think that's all. Is that right, Sarah? Is that all I was going to say? Is there another slide?
Yeah, well, the next slide was just to try and gather some feedback from people. So,
okay, so this is your chance to ask us questions. Tell us what's not helping, what is helping, what you think we could do to help you. I know different people have come up with different ways of handling the audit, so it's interesting chatting to people about the audit, how they do it. I know that our department put all our data in ourselves. Some of you use an audit department to enter data. Some of you have got data clerks. We've talked in the past, I know, about challenges with the national data opt-out and so forth, but we're very happy to liaise with you about that. I can see there's a question coming in about the email collection request should be on a patient-facing form, not as currently on the clinician form. Okay, so all you have to do is put on the NEIAA audit, the email, the actual email. I appreciate you have to ask the patient that, but you have to ask the patient lots of questions. I routinely say to patients when I fill in the audit in front of the patient so they know what I've put in, and I say, are you happy to participate? Are you happy to give us feedback? Can I have your email address? It doesn't, if the patient says no, that's fine. They don't, and some patients say no, they don't want an email, but they're happy to be in the audit. That's fine. We don't have to, we're not looking for 100%, so that's fine. But what happens is, oh, I'm not in clinic, rather the doctor seeing the patient. Okay, so well, there's no way around that unless, so most trusts, mine included, do not collect email data routinely. So all we collect is patient telephone numbers. Unfortunately, we took that box off the audit because if you put a patient telephone number in, nothing happens unless you ring them and ask them to fill in the forms and facilitate that. I know 1 or 2 departments who've been very organised have managed to get patients entering data directly via tablets in the waiting room and so forth. But the trouble is that needs manpower. I personally, in our department, we haven't got that manpower, so we've had to come up with a simpler one. So we just ask for the email address. If you input the email, you don't have to do anything else. BSR does everything else. They contact the patient, they ask the patient if they're happy to participate, and they send out the forms automatically. The trouble with patient-facing forms is that's going to involve a bit of paper, isn't it? And we're trying to move away from paper. We're trying to keep this as electronic as possible, and you know, and remove paper from the system altogether. But if anyone else has any innovative suggestions for collecting emails, then please do shout up, because I think the only way to do it actually is to ask the patient. I can't see any way around that, and I imagine most of us are seeing patients face to face, so, or even on telephone, you can ask them, can't you? Any other questions?
We had just another comment earlier that I thought would be good to touch on is Jacqueline Evans also mentioned that a significant number of their patients have opted out of data sharing, and that's reflected in their figures. Now
that's interesting. So there's 2 things about data sharing. There's the national data opt-out. I'm surprised it's a significant number. I think UK-wide it's 0.1%. Is that right, Sarah? I think the figures are gone.
4%.
4%. Okay, so
4%.
you're out of kilter if you're significant. So NDO. So someone's asking about the NDO, the National Data Opt-out. Now there are lots of different ways around that, and I'll share with you some of the ones that we've heard about already, and I'll share with you what we do. So we thought this was going to be insurmountable because we don't have the audit department involved. But I spoke to the audit department, and they did initially somewhat reluctantly agree to help us with this. So audit departments can tell you if your patients have opted out, and they can do that because they have access to what they call the NHS spine, which stores that data. You won't have access. I certainly haven't got access to it, and it's unlikely any of you will have access to it. So what we decided, 47%, that's unbelievable. That's very interesting. So you must be a complete pocket of oddness in Pennine. So because 4% is the national average. So what we decided to do here, and what they agreed to do, is that we would enter the data when we saw the patient. We'd ask the patient if they wanted to be in and enter the data. And then at the end of the week, every week, they would go through and pull out any, or let us know if anybody actually had signed up to the national data audit, data opt-out. We've been doing that since July the 7th when this came in. We've inputted a reasonable number of patients. So we input about 200 a year. So in the last 6 months, we've inputted well over 100. We've only picked up 1 that was NDO opt-out in that time, 1 single patient. So that's actually slightly less than the 4%, but you know, is what you'd expect. But there may be people that we've asked who didn't want to go in. That's an option. That doing it that way around is fine, because the data, when you put it in, stays locally on your bit of the web until it's pulled up in the national data pool, which happens 4 times a year. You do get warned, you may not realize it, but you do get warned there's a national data pool, and you'll get a little email saying, please make sure your data is up to date as we're about to pull the data on such and such a date. So as long as it's done before that, you're fine. I've spoken to a couple of units where they've persuaded their audit department to proactively look at their clinic lists and tell them if patients have opted out. And then the other option, and I've spoken to another department that have done this, they've actually asked the patients when they send out the appointment to declare if they've opted out. Our experience is most people can't remember this. I couldn't remember if I'd opted out or not because it happened so long ago. I think it was about 10 years ago the national data opt-out was actually launched. It's recorded on your GP records, so your GP will know. It's very interesting. Can I just check, are you checking on the spine to see if they've opted out? Is it truly 47% of your patients have opted out on the spine? Because that's a staggeringly high number and would suggest there's something really unusual about your population.
Liz, I'm just going to allow
Okay.
Lynn to come off of mute.
Okay.
If she wants to, so that
Thanks.
we can have a little bit of a discussion around this.
And
Jacqueline, you should now be able to turn on your mic if you wanted to.
Yes, I am.
Shall I just answer the, oh, hi there, hi. So is that true?
Hi.
47%, that's staggeringly high. The national figures
absolutely.
are 4% and locally we're 1%. So
Absolutely.
is that data off the spine or is that your own data?
It's off the spine. I can go on and check for third party.
Gosh, that's staggering. That's very odd. We should raise that actually, Sarah, because that's so out of kilter as to be almost, you know,
Yeah.
you almost don't believe it. How can you be 10%? How can you be 10 times the national average?
Well,
That's just.
I don't know where that information comes from. I'm just
No.
my experience of checking.
Yeah.
And I think a lot of patients do not.
Are you in the
appreciate what they have
northeast?
opted out. Northwest.
Northwest.
Okay. All right. We'll look into that for you and we'll come back to you with an answer because that would be extremely odd, and there may be local regional reasons for it. I don't know. Andrew Costello says that oh no, I'm sorry, I'm one behind. Kerry Cooper says audit department don't have access to the spine. I would doubt that's true because our audit department do. You have to go via, but so the audit departments in most trusts have to do this regularly for the hip fracture audits and other national audits. So they should, if they don't have direct access, you should know how to do it and they should be able to do it for you. I'm very happy to, if you want to get back to us, I can write to your audit department and say this is something the audit department should be doing. It's an audit department function and it should be done by audit department. You shouldn't have to run around sorting it out yourself. Okay, but you go via the BI. But in that case, you presumably have a process to do it because you have to do it for the hip fracture audit and the stroke audits. So maybe I'm not sure if you're muted, but you can always answer in the chat.
And someone mics, Liz. Let me just turn everybody's option and then people can raise their hands. I think this is a useful conversation to have. So
yes, I think it is.
Give me a second, people, if you want to raise your hand if you have a question.
So Kerry, maybe you can tell us how you manage with all the other audits. You just have to go to the business BI department for it, but you must have a process for doing that. Yes, we have a log. We log a call. Okay, fine. Okay, so I can tell you, I don't know how long it takes you, but my audit department admitted that it takes them 15 minutes a week to do this job. So they go in on a Friday, they pull all the NHS numbers of the patients entered that week, and it takes them 15 minutes beginning to end. So it isn't a huge job. And actually, given that this is a HQIP mandated audit, we pushed very hard for them and it's the only involvement they have. We do everything else. So they did agree to do it. And Andrew Costello, so they've been struggling to get clinician engagement. Yeah, that is difficult. I appreciate that. And as I say, I've spoken to some departments who are absolutely on their knees, and this is just like the straw that breaks the camel's back. There's a couple of things about that. First of all, most of those departments are massively under-resourced, just haven't got enough clinicians to cope with the catchment population. And so we've been pointing that out to trusts, and I'm happy to do that for your trust if you contact me and that we can have a chat about it. And audit departments have variable input. I've spoken to a couple of departments that have got really good audit engagement, whereby the clinician just basically gathers. But the trouble is, it still involves gathering the data. So the clinician gathers the very basic data, and then the audit department upload it for them. It does vary trust by trust, depending on how much resource the audit department are happy to put in. But again, I'm very happy to have a chat with you and your audit department if they're not supporting you at all, because this is something that HQIP expect the audit department to get involved in. Any other comments? Oh, someone's got a hand up. Andrew, you can.
Andrew. Yeah.
Hi.
I actually manage the audit department.
Oh,
so,
right. Oh, well done.
yeah.
In that case, you're on board.
We are on board, and up until last year, we had quite good clinical engagement, but we are
Yeah.
struggling now. I'm liaising with
Okay.
the business manager who's on this call as well. So we're just
Okay.
looking at ways of how we can support the clinical team, given that it's a mandatory national audit, and how we could
Yes. Yes.
help them submit data based
Yeah.
on the data set that's captured.
Yeah, so I know that in Wales, I don't know if anyone from Wales is on the call, they have an arrangement whereby the audit departments pull the data out of clinic letters. It does, the onus is on the clinicians to put the data in the clinic letters,
Yeah.
you know, the DAS score and everything, but that's how they do it there. I've spoken to a few departments that have a little pro forma that doctors just fill in clinic, and then the audit department sweep them up at the end of clinic and enter them, and some that have like a little online form they fill in. It's worth pointing out to your departments that actually the data collection burden has significantly reduced, and people who haven't been into it since before April won't appreciate that. But there's far fewer things to collect, far fewer. So you might want to have a look at what the new data collection is and maybe design a form. Or have we got any forms uploaded on our website, Sarah, for this? We have. There we are. We've got data collection forms. Yeah, yes, downloadable form. So maybe go about it that way. But again, if you think it would be helpful for me to talk to your clinicians, because I've been contacting who I think is the lead. It's usually a clinician actually, and sometimes an audit person, and speaking to them. And I must have done about 25, 26 one-to-ones already, with people, picking up the issues across the UK, and there are significant themes emerging. Yeah. Oh, there are. Someone's put in an email for you to book a call, and I'll get back to you. Yeah. Yeah.
It has been quite striking actually, Liz, just to touch on that, seeing the responses that you've got from some of the services and seeing the notes. I mean, it certainly helps us when managing the audits, knowing what the barriers to engagement are, because we want to be a supportive audit, and actually, Liz, you're willing to make those calls to each of the different services.
And I think, let's be honest, it does vary, but not even from department to department, within a department. So, even within my department, there are people who are more engaged than others. I don't know. It's just one of those things. You're either a bit of an audit person, you're not, I suppose. But this is about quality improvement. And that's the angle I've taken with people. This is not about just collecting data for the sake of it. This is making things better for your department, for your patients, and ultimately the health of all our patients. And what we know a good QI project does is it pulls up performance across everyone. It doesn't leave anyone behind. So we're looking to pull up everyone's performance to a reasonable level. So that's why we're all the data that's being presented to HQIP really is being presented as national data. We are mandated, and this is one of the things this is why I've been contacting individual departments. We are mandated to highlight outliers, and there's two ways you can be an outlier. You can be an outlier because your performance doesn't hit the QS, but it has to be 2 standard deviations away from the QS2 standard. So it has to be pretty low not to hit it. And as I say, there's multiple reasons for not hitting it. And this is not about portioning blame. It's about sorting out how to make you better. The other thing that we've been talking about is being an outlier because you're not engaging or you have low numbers entered. You can, if you think it's a problem with individuals across a department, you can pull data downloads that tell you who entered the data. Now, the problem with that is that that's useful for last year when we should have been entering everyone. But from this year going forward, we're only entering people with a confirmed diagnosis. So, of course, I saw 4 new early inflammatory referrals in my clinic yesterday, only one of whom actually had new early inflammatory arthritis. So although I saw 4, I only uploaded data on 1. So, so it's really difficult to follow how good we're being at uploading. So the reason I didn't upload the other 3 was because they didn't have early inflammatory arthritis, but it might have been because I couldn't be bothered. But, so it's interesting, isn't it? Unpicking all of that. Only QS 1 to 3 are reliable. Has the clinical report data? It is now. Okay, yes, okay. So Sarah's answered that for you. Good. Any other questions I've missed, Sarah?
No, I think you've answered all of the questions, and we're at the end of the webinar. I think that brings us to the end of the slides. It was really good to get that engagement. We do have a feedback questionnaire here. If you can feed us back on the webinar and let us know how you found it, and also if you have any suggestions for what would be useful for future webinars, that would be fantastic. And thank you, Liz, for
Oh, well, amazing. Thank you for everyone for coming along. I know how busy you are. It's been great to see so many faces and to hear the chat. It's been great.
Yeah.
Take
Thank you,
care.
everybody. Take care.
Bye. Bye.
Bye.